Why emotions are so important for us? We know that when we have challenges in processing emotions, then we will have what we call mental health problems. So most of the mental health problems are to some extent related to emotion and motivation, and how emotion and motivation is being processed inside the brain. So most of the psychiatric disorders that we talk about, they are related to emotions and how we have higher level of emotions, lower level of emotions and experiencing, or how we process kind of emotions. So if you just explore different psychiatric disorders, you know that most of the psychiatric disorders you discuss about are related to different sorts of emotions. And that is the reason that I think technically, whatever we start to realize about emotions, they are definitely related to mental health and mental health related issues. And when we talk about mental health issues, in US, we know that at least from every 5 individuals in US, one of them would be experiencing a mental health problem. And it would go to something like 48 million people. So it is a really widespread problem in US and almost around the world. So we know that other places would have almost the same statistics in terms of the prevalence of different mental health disorders around the world. And when we talk about things like major depression, something like 7% of the people, 7% of people are experiencing major depression or major depressive disorders. That will be something like 16 million people. And something like 18% of people would experience anxiety disorder. So we are not talking about, let's say, just being anxious. We are talking about anxiety disorder. By disorder, we mean that it basically affects the quality of life of the people. And we know that something like 10 million people would have both mental health disorder and addiction. So we know that something like 40 million people would experience a mental health disorder, around 30 million people would experience a substance use disorder, and something like 10 million would be shared between these 30 and 40, that they experience basically both mental health disorders, mood, anxiety related disorder, and also addiction together. So that is a huge amount of people who are affected by that. And interestingly, 60% of them, they do not receive any sort of mental health services during last year. So even while they are experiencing all these disorders, something like 60% of them do not receive mental health related services. And I'm talking about US. That we are expecting to have probably better service providing compared to the other kind of less developed parts of the world. And that would cost something like $193 billion per year. So that is huge. So we know that mental health disorders are huge, and there are many challenges. And I told you, as we are discussing about different sort of substance use disorder, we have huge level of people who are experiencing substance use disorder, and it excludes alcohol. So if we include alcohol to this one, that would go to something like 50 million. So the problem would be even much higher. And we are talking about opiates, methamphetamine, different sort of substance use disorders that are kind of major problems here in the US. And we know that all these sort of, when we talk about addiction or we talk about depression, anxiety, all of them are basically problems within the reward, punishment, emotion processing circuits in the brain. So we know that these kind of circuits are affected, and we are talking about the deficit in these circuits. And if we have a good understanding about how these circuits are working, we probably might be able to find solutions for these, let's say, psychiatric disorders in the future. And that is why we think that kind of having a better understanding about neuroscience of these mental health disorders would help us to reshape the future of mental health and psychiatric treatment. If we want to have a kind of a better look about what we are talking about, let's go for something that seems a little bit simple in terms of its definition and the experience that we all might have experienced before in terms of being depressed for a while. So trying to understand what do we mean by kind of major depression or major depressive disorder or major depressive episode, and trying to deconstruct what we call depression. Is depression a single disease that we just have lower level of mood? So is this what we are talking about? Are we talking about just let's say if we have just one single knob in the brain which is related to mood, and then the knob is just turned down and we have just lower level of mood? Is this what we are talking about? Or it is much more complex than just thinking about lower level of, let's say, interest to life? If you want to think about that in that direction, in terms of just thinking about what we call hedonia. And by hedonia, I mean how we take pleasure from our normal life. That is what we call hedonia. And hedonia would be how we just cannot kind of experience pleasure in our life. And there is a questionnaire for that. It's called SHAP or SHAPS that we use to measure hedonia. I was thinking, Panyan, you had a kind of a Google Doc for that. Do you still have that? Could you share that with others? Is this something that is available or not?
Yeah, sure. I'll just share the link in the chat box. Just a second.
Okay, that would be nice. So if you are interested, you can just take that questionnaire and see what do we have there. Obviously, we cannot take confidentiality for that information, and we are not going to use that information in any way. So, I mean, if you like, you can report what you really experience, or you can just report whatever you like to report. So it's just to give you a sense about what do we mean by anhedonia or hedonia, and which seems to be the main core of what we call depression. So people who are depressed, so obviously their problem is that they cannot enjoy their life. So that is the main, let's say, dimension of what we call depression. Okay, so looks good. So you can just click on the link and just go and answer those questions to just have a sense about what are the questions about in Snaith-Hamilton pleasure scale. So obviously there are questions there in terms of whether you enjoy from being with your family, reading book, what are the things that would make you feel good and take enjoyment from these activities. Let me just share this link with you. There is another questionnaire that I want you to, let's say, try. It is not in our website, so it is just an external company, so we do not have any interaction with them. We are not collecting information for them. You can report whatever you like there. It is just something that I found on Google search. Just kind of a link to one of the questionnaires that we have, which is called the PHQ-9 questionnaire. So this is another question that we use to measure things that are related to depression. And we use that for screening depression. So please go ahead and use this one. And then I will ask you a few questions about your experience. Zainab, could you tell us your experience in terms of how you differentiate PHQ-9 from SHAPS?
Well, the SHAT questionnaire was much more objective in terms of the examples that it gave us. But the other questionnaire, the PHQ-9, was much more subjective and more common, I think.
Mikhail, what was your experience?
Well, for me, the SHAPS measures hedonia specifically, which is perhaps one of the core aspects of depression, but the PHQ-9 is much broader and also evaluates clinical importance. So it's more of a screening tool for depression in general for me.
So when we talk about PHQ-9, it's just a screening tool, but Beck depression gives you a measure of severity of depressive symptoms. So yeah, of course, I mean, as PHQ-9 is something that is a screening tool. Right now in our hospital, what we do, there is an arrangement that we are collecting PHQ-9 from every individual who is attending any outpatient setting inside the hospital. So if you go to a cardiology visit today, you need to fill in a PHQ-9 to have and we are collecting that in terms of having a sense about what is the distribution or prevalence of depression around the patients that we receive inside the hospital. So that is a kind of a screening tool. But the important part is when we talk about hedonia or anhedonia, or what we had with let's say SHAPS, there are people who are positive or negative, and when we add, let's say, PHQ-9, you can imagine that those who have higher scores in PHQ, let's say those who have both, let's say that the higher would be less hedonic, and this one would be depressed, less depressed, something like that. Just trying to make a kind of a dimension. It's quite interesting that people could be in all these, let's say, dimensions. So we might, I mean, technically we feel that, okay, those who are anhedonic, people should be here. I mean, they have anhedonia, and also they have higher score in PHQ, so those are people who are depressed. But you might still have people who are depressed without having a really high level of or low level of hedonia. So that we might have people here as well, and there are of course people could be in other zones as well. So you know that these let's say instruments are not 100% overlapping. So there are other dimensions to that, and people realize over time that okay, hedonia is an important concept, but hedonia is not covering whatever we know about depression. So there are people who do not receive a high score, or they are not considered as anhedonic based on the SHAPS measure, but they are still considered as depressed by PHQ-9. So how these two dimensions could be, or these two instruments could be different in terms of not having anhedonia as the main core, but having other dimensions to what we call depression as a psychiatric disorder. There are some other instruments like Hamilton Depression Inventory, and I mean these instruments are being used by clinicians, so they are not self-reports. So we use them as a kind of a clinician-driven instrument. So you need to see the patient and then let's say rate. Okay, this patient would be, I would rate him as something like 3 in depression. The guilt feeling is 2. Suicide is 0. Insomnia would be 2. So you start to just give them, let's say, scores for different dimensions. And just one of these dimensions, whether the patient is doing the work and activities and enjoying them, that is the only thing that is in SHAPS. And there are some other aspects of depression, even in things related to weight. Do they have insight? How is their sexual function? And how things related to, let's say, anxiety, agitation, those things would be also included in the process of diagnosing what we call depression. So when we call depression, it is not just having a lower level of hedonia. There are other dimensions to that. And that makes things complex. So you would start to see patients who are different from each other. So it is not just something like, as I told you, one single knob, you can just turn it to one direction or the other, and that would be depressed and non-depressed. So you can see that people who are depressed, they have different aspects to their depression that are sometimes confusing to understand. So what we feel right now is that the symptom-based diagnosis that we are using, as I told you, just based on the self-reports, the symptoms that people have, we have different people from different, let's say, underlying diseases. that would be labeled as, let's say, major depressive disorder, or those who have what we call dysthymia or bipolar depression. But in reality, if we use, let's say, their genetic risk factors, brain activities, physiology, some more detailed phenotyping and genotyping, these people would have in 2 different clusters. And then each cluster would need different sort of treatment. Treatment 1 for this cluster, treatment 2 for this cluster, treatment 3 for this cluster, treatment 4. So we need different treatments. And the reason that when we kind of give treatment to people with major depressive disorder, the treatment response is not really good, because we really don't know what is happening there. You know that with the first line antidepressant medication that we are using right now, the response for the first medication would be something like 30%. And there is something like a list of some 5, 6, 7 different medications that we can use for the first line. And we really don't know whether to give number 1 to the patient that you have today, or number 2 or number 3. There are some hints that this might be better, this might be worse. But most of the time, you just do try and error. You just give them the first medication that you think that is going to work. It would work for something like 30%, and then you change the medication. Then the response rate would get something like 50%, and then you give them for those who are not responding, you give the third. So you just try and error to find, okay, because the first medication was targeting the yellow group, the second medication was targeting the blue group, and you really don't know whether your patient that you have is blue, red, or yellow, but you are just giving them medication or different sort of interventions randomly, hopefully finding the right kind of treatment for them. But what we try to do, we try to use neuroscience and other understandings to be able to cluster them, to give them the right treatment that is going to work for them. So that is the idea of, let's say, what we call personalized medicine, or what we call basically precision psychiatry. So that is the idea that we are hopeful about that. And there are specific, let's say, attempts for that. And I'm just going to give you one single example that might be interesting for this direction. This is a paper that is published in Nature Medicine. Those who know Nature Medicine, do you know the impact factor of Nature Medicine? What is the impact factor for Nature Medicine? Do you know that? Yep, 36. So it is pretty high. It's damn high. It's just really, really high. And you know that, I mean, that is really, really high in the field. And I had a talk about that with details in Iran Psychiatric Institute 2017. So I think it is still available. Yeah, I have a kind of a talk about that in one of the webinars online. So it should be on my YouTube channel. Unfortunately, it is in Persian language. So those who understand Persian language, they can use that. But that is a paper that is published in Nature Medicine. And then it is being considered as the most influential paper in the field of psychiatry for publication in 2016. So it was considered a really important paper in the field. So what they have been trying to do with this paper, I'm just giving you a kind of very simple shots from the paper and the idea that we had in the paper and people had in the paper. So they tried to use Hamilton Depression Scale, so HAM-D, and using HAM-D, they realized that people with a specific analysis method that we call Pearson canonical correlation. So canonical correlation is an interesting sort of analysis. I'm not going to discuss about canonical correlation, but basically with using this specific analysis, they realized that we basically have 2 dimensions in Hamilton depression. One dimension that would be related to question number 7 that we saw before, that is related to anhedonia mainly, and then psychomotor retardation. Okay, so these are the factor loading for these 2 dimensions. And then, as we have discussed about what we call the kind of work activity and how they are being basically scored, and then psychomotor retardation, which is being slow and less agile, so that getting sort of clumsy. That is called the psychomotor retardation. And then there is another factor that would be mainly loading towards anxiety, insomnia part of Hamilton depression. Things like kind of how much anxiety you feel, do you have problems in going to kind of to sleep, or just getting out of the sleep without kind of your own kind of will, and just trying to, it would get hard for you to be back to sleep. So that's the second dimension. So the first dimension, second dimension, and this is the loading of other factors, as we saw in the Hamilton depression. These are different factors. As I told you, the anhedonia related factor would be mainly loading to the anhedonia, and the anxiety related would be mainly related to, let's say, anxiety related items. So they try to basically separate two different, let's say, dimensions. And then they showed that there are specific neural markers in the resting state that are related to anhedonia. So as you can see that they are highly correlated. The anhedonia related connectivity score between these areas and the specific score from that anhedonia related dimension, they're highly correlated. And it's true for anxiety as well. So they found that there are specific areas that are related to anxiety related clinical score, and there are specific areas that are related to anhedonia version of the kind of depression. And there are some other, let's say, analysis involved. I'm not going to get into the details of analysis. Those who are interested, they can see my talk about that. And of course, you can find, there are talks from the group of authors that we have in this paper, that people have in this paper. So you can see their talks as well. And they basically made a hierarchical clustering, as we discussed about in last session, if you remember. In the hierarchical clustering last session, we discussed about how to cluster different brain activations. Here, they try to cluster people. So they put the entire sample size, the entire sample that they had of different participants, and they try to cluster them in 4 clusters. As you can hear, these are 2 dimensions for this clustering. And there are patients who are in cluster 1, cluster 2, cluster 3, or cluster 4. For example, those who are in cluster 1, as you can see here, they are less anhedonic and more anxious. So, I mean, this is basically that cluster. Or those who are in cluster 3, they are more anhedonic and less anxious, as you can see here, based on this, let's say, dimension that we have. So these are different clusters. It is not really important in terms of defining whether they are related to anxiety or anhedonia, but at least they show that they are differentiated. Okay, so we already have them in different clusters, a sort of a neuroscience informed clusters. Okay, but it is not something meaningful. So just having people in different clusters, it doesn't mean anything. So you cannot publish a paper to this level in a, let's say Nature Medicine journal. You can publish it in something like a journal with impact factor of 3, 4, 5, something like that, but not more than that. But how can you go beyond that? How can you go beyond just clustering patients based on some information to some groups and saying that, okay, I mean, there are different clusters? You should show that there are interventions that are effective for one cluster but not in the other clusters. And then showing that if you know the patient that you have is in cluster 1 or cluster 2 or cluster 3 or cluster 4, you can predict whether the patient is responsive to treatment or not. So these clustering methods are going to be important if you can use them to predict the treatment response and to do treatment selection. And this is exactly what they have done. So they basically tried a specific sort of RTMS intervention. I'm not going to discuss about the specific intervention that they use for RTMS. And they showed that if you are in biotype number 1, you would have 80% response to that. But if you are in biotype 2 or biotype 4, your response would be something like less than 30%. So the conclusion was, okay, if we do resting ST fMRI, we kind of predict who is going to be responder, who is we put people in different clusters. Based on the cluster, we can say whether this treatment is going to be helpful for them or not. And that is the reason that they were able to publish that in Nature Medicine, because this is exactly what we need from neuroscience, to be able to differentiate them in different clusters and being able to predict, okay, if you are in this cluster, then we boom in this part of the brain, we do the intervention in this part of the brain, and that is going to be effective in terms of the kind of modulating depression or whatever else that we have as a psychiatric disorder. So this is the reason I'm talking how this is going to be important in terms of doing the clustering and putting people in different clusters. And this is the end of this part.